Good morning, everyone. We want to welcome you all to what, for many of us, is a very exciting announcement today. We are taking a very significant step to promote better health for district residents, to prevent behavioral problems, and what we believe will help to build stronger communities. We are establishing a new Department of Behavioral Health to integrate treatment for district residents who have mental health challenges or substance abuse disorders. And this will be essentially a merger of the Department of Mental Health and the Addiction Prevention Recovery Administration, which is now in the Department of Health. This will bring them together. As many of you know, we have more than 35,000 residents who are receiving treatment for either mental health or substance use disorders. A significant number of those folks actually have both, the co-occurrence. Our best estimates are somewhere between 30 and 50%, which, if you do the math, would be somewhere between about, 6,000, 7,000, and up to about 17 or 18,000 people who experience both conditions. And of course, without integrated treatment, one or certainly both of these conditions would not be addressed as well as they otherwise might. Mental illnesses and substance use addictions both are biological brain disorders, in some instances with genetic and certainly with neurobiological factors associated with them. As we learn more about how to support individual recovery and resiliency, research shows that treating both illnesses jointly rather than separately improve outcomes, and that's what this new department will be designed principally to do. We know that treatment is effective and people do recover, especially if recovery services are included in the continuum of care. We're putting the best system in place that we believe can make that happen. The overall vision of an integrated system is to effectively serve individuals with co-occurring disorders, whether they seek help for mental health or for substance use disorders. According to the Federal Substance Abuse and Mental Health Services Administration, which is commonly known as SAMHSA to many of us, integrated treatment that addresses both mental and substance use conditions at the same time leads to lower costs and better outcomes, such as reduced substance use, which of course would be one of the principal goals, improved psychiatric symptoms and functioning, decreased hospitalization, increased housing stability, which is a huge issue for us here in the District of Columbia, fewer arrests, and perhaps principal importance, improved quality of life. On the other hand, the consequences of undiagnosed, untreated, or undertreated co-occurring mental and substance abuse disorders are severe, and we have seen the consequences of that, unfortunately, many times on our streets. There are any number of people who we see who present as being homeless, who also are people who have the co-occurrence of mental illness and are experiencing a substance use disorder. Studies have shown that compared to individuals without co-occurring disorders, people with co-occurring disorders are more likely to be hospitalized, they're more likely to be homeless, as I indicated, or even incarcerated, as well as infected with HIV, hepatitis, and other infectious diseases. Effectively serving individuals with mental health and substance use disorders means early detection, as well as integrated services that are individualized and responsive to all of these conditions. A new Department of Behavioral Health will do the following. It will ensure that every individual seeking services is assessed for both mental health conditions as well as substance abuse needs. Will develop the ability of the provider network to treat an individual for both mental health and substance abuse disorders at the same time, and frankly will help to further integrate our own provider network here in the city. I think we have, when you put the two provider networks together, we probably have somewhere in the neighborhood of 80 providers who provide either mental health services or substance abuse services, or in some instances both, and this will create a more integrated system. It also will focus on recovery as the goal and measure of progress, and will enhance monitoring of providers to ensure high-quality services. With the creation of a new Department of Behavioral Health, we also want to increase public awareness and focus public policy attention on the role of behavioral health by engaging all areas of our community. That would include, of course, obviously elected officials. And by the way, Councilmember Alexander, who now has oversight of the health areas, wanted to be with us today. She has the flu, and she is down. Otherwise, she would have been here. She was quite excited about being here to be a part of this. And I know she will work closely with us as we move forward with this. In addition to elected officials, obviously advocates, health professionals, researchers, and of course those who are directly affected by either of these conditions, or in many instances both. SAMHSA estimates that by 2020 mental and substance use disorders will surpass all physical diseases as a major cause of disability worldwide. I hope you heard that. Will surpass all physical conditions as a major cause, or as a cause of disability around the world. We want to challenge assumptions that blame individuals or create misunderstandings and prejudices that make people reluctant to seek treatment. Instead, we're taking a public policy approach based on facts and a scientific understanding of mental illness and substance use disorders. We are focused on prevention, recovery, and building healthy communities as a fundamental outcome of all of this. Over the next few months, Steve Barron, who is currently the director of our Department of Mental Health, who really has done an outstanding job. Steve has helped lead us out of the Dixon order, which I think is the longest standing court order in the history of civilization. It, I think, was entered into somewhere in 1974, 74, and that would be a long time ago. Just to give it context, it was before the advent of home rule in the District of Columbia, and we now have been relieved of that court supervision. So Steve will play a principal role in this, along with our interim director of the Department of Health, Saul Levin. We've had any number of meetings and discussions about this, so I think we are ready to start the process. They will lead an implementation process that will involve every one of our partners here in the District of Columbia, including community-based providers, as well as people who have the co-occurrence of mental health conditions, substance use conditions, or their families in many instances. We know that treatment is effective, and we know that recovery is possible for so many people. This new Department of Behavioral Health, we think is the best way in 2013, and certainly for the foreseeable future, to support healthy individuals and a strong community. So I'm personally excited about this. Some of you probably know that my background is in human services, that my training is in clinical psychology, so I can't wait to roll up my sleeves and get involved in this. Was the director of the Department of Human Services at one time, and we did a lot of work with what then was called the DASA. Anybody remember the DASA? And of course became APRA. And this is the next logical step to me, and that is to be able to integrate two services that have a natural relationship to one another, all for the betterment of people who will be served by this new department. So I want to call upon a few other people. We want to start with the two people who will lead this effort. First of all, I want to ask Steve Barron to come up. indicated, he is the director of the Department of Mental Health, obviously quite an expert himself. And then we'll have 2 or 3 others, and we'll be happy to take questions after that. Steve?
Thank you, Mr. Mayor.
Absolutely.
Thank you, Mayor Gray. We're tremendously excited about this opportunity for the district. I think when you look around the country, you look what's happening, what's the best way to deliver services, it has to be an integrated approach, and it has to benefit the person who seeks treatment. So that's the goal. How do you make this from our macro structure of creating a new system, a new department, that when an individual, a district resident, walks in needing services, they get enhanced care. The mayor is very, very kind about the Dixon reference, but it can't go without saying his leadership and bringing us over the finish line was tremendous, and his enthusiasm for this department has really pushed Sal and myself. So, he's covered all the major points in the talk of the benefits. We're not going to spend a lot of time on that, but Sal and I are very much committed to involving the community and all the various stakeholders. You're going to hear from a couple of our agencies. We also have Carol Parks here, who's the director of the president of the DC Behavioral Health Association. And I want to also make sure we recognize Carol. But Sal and I are going to work very closely with our staffs and with the whole plan that we put together with Deputy Mayor Otero to make this happen. So, Mr. Mayor, I think your leadership has been instrumental in moving us to this point. So thank you.
All right, we want to have the other person who will co-lead this effort, who is currently leading our Department of Health. The Department of Health will essentially remain intact after this. We will simply carve out APRA and the substance use services and then merge them with mental health in the new Department of Behavioral Health. So, Dr. Saul Levin, come on up.
Thank you, Mr. Mayor, and I also have to thank Deputy Mayor Otero, who's here with us, because your 2 leaderships have clearly helped us in the field, both from the mental health and the substance abuse side, really begin to bring us what I think we need to go back to the Affordable Care Act was really looking to achieve. And that was through the funding of the Affordable Care Act and the financing of what will become the continuum of care for all patients in this country. In some ways, this creation of the Department of Behavioral Health makes perfect sense at this time. While SAMHSA and myself as a psychiatrist obviously has believed that you cannot separate mental health and substance abuse from each other, it has taken the country in some ways a little longer to get to the idea of saying if we can finally get the co-occurring disorders of mental health and substance abuse being treated from the moment they enter either the prevention or for treatment and then the recovery, we will get a lot better outcomes coming into it. And as we all know from the primary care side, chronic diseases have a very strong mental health and substance abuse component to it as well. So in some ways, this continuum of care is going to be very, I think, going to add great value, not just to the city, but to our patients themselves. And I have to thank the mayor, and the deputy mayor for also making sure that we see this as not just 2 administrations coming together to form a new department, but also that the community comes along with this as well, and that everyone should be doing an assessment for all areas of mental health, substance abuse, HIV/AIDS, chronic disease, because in the end, the patient has a biopsychosocial way of living. There's biological components of illness, there's the psychological components of illness, and of course then the society components of illness. And I think this makes perfect sense to us, and the Department of Health is really looking forward to working together on this, Mr. Mayor. I have to just recognize, Mr. Mayor, our interim director or interim senior deputy of APRA, who essentially will also be spearheading this in some ways. She's the one who's now looking after APRA, and it's been wonderful to have her. So I have to thank her and her staff here. Yes, and Miss Frances Buxton, Miss Frances Buxton, who actually comes with the most amazing, so I thought I'd said that. who actually heads up the area of regulation and certification of all the APRA providers, the 50 APRA providers, and in some ways has a very strong mental health component as well. So as we look to all the different components of creating this department, I think you're going to see the staff of mental health, the staff of APRA, the staff of DOH really come together to really enhance the continuum of care. So thank you.
We have a couple of other people that I'm going to ask to come up. First is Dr. Richard Bebout, who is the Chief Clinical Officer for Community Connections, which is a long-standing, outstanding provider here in the District of Columbia. In addition to that, Tony Zollicoffer, who is with one of our outstanding provider organizations as well, so others might eat, which is a renowned organization in the city, and now is working with us around workforce development issues as well. And he doesn't know I'm going to call on him, but he was identified earlier. He's the head of the Behavioral Health Association. That's Carol Parks. I'm going to ask him if he would like to come up and just say a few words along with the other two folks. So why don't all three of you come up? We'd be delighted to hear from you as we move forward with this.
Well, thank you, Mr. Mayor. I, as a longtime provider and advocate and as a DC resident, representative of one of DMH's largest providers and also one of APRA's newest providers, I'm really just thrilled to be here to congratulate Mayor Gray, Deputy Mayor Otero, Mr. Barron, and Dr. Levin on their vision for a new unified behavioral health, Department of Behavioral Health. This reorganization is very much in line with what is happening across the country and other progressive jurisdictions, and really opens the door for integrated care. A change simply in terms of the government architecture won't guarantee anything, but it is really very gratifying to hear all the way to my colleague and my clinical psychologist colleague, sort of a deep understanding of how these problems, not just occasionally, but most often interact in complex reciprocal ways. And so I'm glad to hear that there's real ambition for this reorganization, for this not to be a cosmetic change, for there to be a commitment to recognize and address right away multiple interacting problems, no matter what door people walk through. At Community Connections, we see thousands of people every year, and most of them in their lifetimes have these kinds of problems interwoven and certainly we know complicated by frequent exposure to traumatic violence and the crushing weight of poverty. So making it easier for people to get what they need regardless of what they come in the door asking for is really very, very exciting. I also want to just say that mental health and addictions services have very rich, long, and somewhat different traditions. And I am very hopeful with the leadership that we have here that the folks in the provider communities will wrestle with each other in earnest and honestly and respectfully about the different mental models and assumptions and beliefs and values that drive this, because in the end, the people coming through the door need us to see people with problems, not problems and parts. And if we can do our part to seek common ground and common language, this opportunity really creates the possibility of really effective, efficient delivery of much more effective treatment and robust care, and making it available and making hope possible for recovery. We know, as was already said, that from data we know, what we all know in our bones, which is that people get better faster the more things they can bring into one place and get help with simultaneously. So again, I just really am very excited to hear the depth of commitment and the depth of understanding that underlies this change, and want to thank Mayor Gray and his team for putting us on this path and for your leadership. This is a good day for tens of thousands of district residents that will be better served in the future because of your vision.
Thank you, Mayor Gray, for allowing some to be a part of this. I echo the excitement. And as some of you know, SUM provides health, dental, mental health, and substance abuse treatment to thousands of low-income DC residents annually. We've recognized that integration of services is crucial to the well-being of the people that we serve, especially those with co-occurring disorders. Approximately 55% of the clients that we see have co-occurring disorders. When it comes to treatment, dual diagnosis, that is mental and addictive disorders, is an expectation. It's not an exception. Therefore, discontinuous treatment doesn't make sense. And although we've provided integrative care along with a few other service providers in the city, we've done it with difficulty. We've had challenges and duplication of effort and documentation and reporting, fragmented systems of care. But we continue to plow away because we believe that people get better when systems of care are truly integrated, and we could do more if the systems were easier to navigate. Thoughtful integration of APRA and DMH holds the promise of creating dynamic, enduring, and interrelated systems that welcome individuals with complex needs into hopeful, caring, and integrated relationships. It supports recovery, and it organizes all staff to deliver services that match no matter where the client walks through the door. The complex needs are achieved and their recovery goals are met. And so we're very, very excited to be a part of this. You will find us a faithful partner. We will continue to work with you, alongside you, as the devil in the details, as we start to go through the details of this. But on behalf of SUM, we thank you for this huge step, and we thank your team, and you'll find us a partner to work with you for this. Thank you.
Good morning, everyone. I was invited, but I did not anticipate having the opportunity to say a couple words, but I would be remiss if I didn't take that opportunity. First off, I want to thank the leadership of the mayor for taking this, this issue on, because it really is a very complex issue to try to bring two agencies together and to have those agencies that are dealing with mental health and substance abuse really create policy, practice, and guidelines that actually can help the end user, which is the folks that are getting the care. So I also want to thank Mr. Barron for his leadership and Dr. Levin for as they began to put this process together, because as was indicated, the devil is in the detail. But 35,000, just think about that, 35,000 individuals that the mayor mentioned have some type of a problem. This gives them an opportunity to go to one place, a one-stop shopping, an integrated process so that they can get the care that they need. When I think about what's going to be so important, I call it the triple A's. It's accessible care, appropriate care, and accountable care. And so I'm hopeful that this vision that the mayor is laying out and that the individuals that will participate really stay focused on how we can make sure that individuals that need care have access to care, and the care that they get that is appropriate care. An integrated model, depending on how you look at it, we want to make sure that we give the most appropriate care. And accountable care, from my perspective, is this. Now, in the past, we had APRA over here, and we had DMH over here. Now we have one individual policymaker, one organization that is accountable to ensure that the delivery of the system occurs. So I think this is a great day. As indicated before, 35,000 individuals. And if you look at the numbers, I don't get into all the numbers, but we know treatment works, and I think that this will provide the opportunity for the District of Columbia to provide the care that those individuals need so that so their lives can improve. So I think I want to thank the mayor again for his leadership, Mr. Barron, as well as Dr. Levin and their staff, and because that's what's going to occur. My understanding is we're talking about October 1st of this year, this will become effective. I think the work begins now, but also after that. And I want to say, as the association president of the association, DC Behavioral Health, our challenge will also we're going to bring our agencies together and have them talk about partnerships and collaboration, how mergers and other things might be beneficial, because we don't want to have 80 agencies doing things 80 different ways. So that's a commitment, excuse me, that's a commitment that we're going to make at the association. Thank you.
All right, I want to thank our previous three speakers, Dr. Bebout, Ms. Zollicoffer, and Mr. Parks. Thank you all very much for being here. I also want to, before we open it up for questions, I want to acknowledge the presence. She's been mentioned several times, and I want to acknowledge her myself, and that is our Deputy Mayor for Health and Human Services, Bibi Otero. When I started this journey a couple of years ago, I said to her, I said, you know, integrated services will be one of the most important things that we do. And I've been in this city all my life, and I don't think I know too many people who know more about that than you. And what I asked her to do, frankly, was to give up a career in the nonprofit world and come help us do this. And that is precisely what she has done. And I'm really proud to call her my friend, to call her a consummate professional, and to have her working with us to be able to get things done that have been talked about for a long time. We all know that talk is cheap, but it is really happening. I've said that our agency directors, like the two gentlemen to my right, are vertical managers, and our deputy mayors are horizontal managers. And she is the consummate horizontal manager, getting agencies and their directors to be able to work effectively together. So, Deputy Mayor Otero, I want to thank you for what you do every day for our city. You know, I think one of the exciting things about this, too, is that we now are taking, you know, what has become increased knowledge, an increased and expanded body of knowledge, and putting it to work on behalf of services here in the city. You know, I mean, we all know that substance use disorders have a biological, obviously, and neurobiological basis to a substantial extent. But we haven't always believed that about mental health disorders. The psychodynamics of, you know, mental health disorders oftentimes have been attributed to, you know, familial relationships and lots of other things. But what we have learned over time is that to an increasing extent, there is a biological and neurobiological basis to those disorders, which to me, frankly, means it's even more hopeful because it means that we can unlock the biochemical bases for some of the disorders that people experience. They will have an enormously improved chance of actually getting better. And doesn't that argue also for bringing together what we know is our conditions, substance use conditions that have a biological basis with mental health disorders, and work on them together? I frankly hope that this will improve our chances to attract additional research dollars to the city, applied research, because I think we will have an administrative model in place at this stage that really will argue for us being a place where we can test out new methodologies, those things that are being we learn more about in terms of basic research at the federal level, that we can become an applied model here in the District of Columbia. And obviously this is not just for research purposes. This is more for how do we do better for the 35,000 people in the District of Columbia who need these kinds of services. And I think this puts us on the path. It was mentioned that we will have the official launch later this year. We'll be ready to that extent. But just like any new ocean liner that is launched, it has a maiden voyage. And so that's what will start on October 1st. This will continue to be refined. We will continue to learn a lot about this as we go along. And I hope we never get to the stage where we think it's all done, because it never will be all done. What we've done is create a framework within which we can continue to grow and build and develop and learn and apply these service models in the District of Columbia. So, again, if I sound excited, it's because I am. I'm happy now to open up for questions for any one of the 5 of us who are standing here. Mike?
Mr. Mayor, on October 1st, just so I understand, you anticipate that C will be the director of the Department of Behavioral Health?
Yes. Don't you think that's a good idea?
Steve and Dr. Levin say what the budgets and FTEs are for each of the components that are going to be coming together here?
Well, the APRA and then all of DMH.
Mike, just give me a second to make sure I get it precise. And I have it here with as you know, Ms. Jones is an excellent preparer for myself, and I have it right here. But, yes. For FY13, we have $169 million in DMH with just about 1,200 employees.
And then what's coming in from APRA?
I'll talk to about 30, 33, but
30, 35, something like that.
Right. We have 70 FTEs in APRA, and then we also, because of the federal block grant, we have block grant employees as well. That takes us up almost to 91. And the dollars are, at this moment, I think it's around $32 million for substance abuse coming from both federal block grant and also local dollars.
Does that include your federal dollars too, Steve?
That was our local number, the 169. I think we hit around 190 when you include everything.
The 32 was with everything. The 32 for APRA.
So, go ahead.
And in some ways, one of the big differences between mental health and substance abuse is that substance abuse gets a larger portion of block grant dollars proportionally compared to mental health. So in some ways, even though we have a choice program here in the District of Columbia paying for any treatment of anyone who wants it, and obviously we're moving towards Medicaid payments, the block grant is very significant for us in the substance abuse arena.
Can the two of you just sort of address what the challenges of the combination are going to be? Is it just shuffling people around an organization chart, or is there?
So,
I mean, is there physical relocations going to take place?
Yeah. We can't. We're not at the point to think about physical relocation. I mean, APRA's right down the street from us, so it's not a big challenge there. I think when you get into the inners of an organization working from the outside, particularly from the providers, you heard around certification, accountability, reimbursement structures, data collection. The mayor highlighted a great point. It's a wonderful opportunity for research. And how do we consolidate and build on the synergy in both areas so it is seamless from the providers? That's going to be basically our biggest challenge is how do we revise our policies so they are consistent and oversee both? How do we make sure the certification process addresses both? There's challenges on the confidentiality side because the federal confidentiality on substance abuse is different than mental health. So we're going to, Sal and I and Deputy Mayor Otero are going to be mapping out a pretty intensive planning process that will involve a number of internal and external stakeholders or partners to help us address these issues. Some are very much inside baseball, but they will have an impact on our external partners, and others around. We also will be looking hard at access to care and quality of care and the important things. So.
And I think one of the other areas that, as we look to this integration, is you have still some portion of patients who are solely mental health disorders, and some who have solely substance abuse disorders. But then you have this very large co-occurring disorders. So in some ways, as you merge the two departments, it's sort of like the three legs of a stool. That in some ways we will still obviously have substance abuse, mental health, but it's that co-occurring intersection where clearly we will actually begin to create, both hopefully within the administration, a cadre of new providers, as well as then hopefully going into the community and helping the communities begin to also create those cadre of joint co-occurring providers of care.
That's right. That really is an excellent point, because we do have a lot of providers who are single condition providers, either mental health providers or substance use disorder providers. What I think this will facilitate is people developing an expertise not only in both, but in the overlapping nature of these. That's the more important issue, the overlapping nature. Not that I do this and I do that, but I do this, if that makes any sense. And that's again really the excitement of all of this. We don't have the. This is not the right forum to talk about reimbursement methodologies, but Medicaid is the biggest source of funding in the District of Columbia. It is the biggest budget. Healthcare finance is the Department of Healthcare Finance is the biggest budget in the city. It's well over $2 billion, and there are additional opportunities, in my opinion, to generate Medicaid dollars when we put these two functions together, because they will just simply work in a different way. You'll have people who are reimbursement methodology experts who will look at reimbursements differently in the city as a result of mental health and substance use disorders now being administered under the same umbrella. And it won't be, we obviously are not in a position to articulate that today, but you're not going to walk up to the Department of Behavioral Health and say, there's the APRA stuff over there and there's the mental health stuff over there. That would be mindless. The idea is to integrate basic functions and having them working together in the months and years ahead. By the way, the questions are from media. If you're a media person that we don't know, please identify yourself. I know Ben, I know, yeah. But I saw the gentleman's hand back there. Are you media? Pardon?
Yeah, my name's Rob Fleming. I've been doing a e-newsletter for 13 years on substance abuse in the District of Columbia. For almost all that time, DC has been rated at the very bottom or near the bottom of the worst substance abuse problem in the country, and very near the bottom on the biggest treatment gap in the country. And what I would like to know is, how is this going to change that? Are the efficiency gains that you're expecting enough to overcome that, or is there going to be some change in tactics? I would also mention that in the past 10 years, the funding has actually declined. So is there any more resources going into this as a result of the merge?
Well, obviously we hope that there are improved efficiencies as a result of this. I don't know how there couldn't be, to be honest with you, given the relationship between treatment modalities, the relationship between the functions themselves, putting them together in an integrated way. I don't know how they couldn't improve. But let me ask the two gentlemen who administer these functions separately now if they would speak to how they view this.
Thank you, Mr. Fleming. I think while you do say the statistic, of substance abuse in the district, we have a long way to go to taking care of all the people who have a substance abuse problem. I think part is the problem has been that we've not taken care of the total patient and some of the other illnesses that go along with substance abuse. So the mental health component, if you're depressed, you don't know what to do, substance abuse is an easy out, if you don't have access to treatment. So in some ways, as we look and say in primary care, if you get depressed, if you have increased weight, if you have diabetes, that brings in mental health, it brings in substance abuse. If you have pain, because you're overweight and your bone structure. So in some ways, I have a very strong feeling that the merger between this will help us enhance the total patient care, that we can begin to address mental health, substance abuse, and obviously the health components of this. And in some ways, this department will begin to work a lot closer with the medical homes that clearly we are beginning to have in this country of primary care, substance abuse, mental health. And I think the last thing is in terms of funding. As you know, APRA has this past year gotten the SPA, the State Plan Amendment, to be able now to bill Medicaid. And in some ways, that will bring in not only additional dollars in terms of payment for the system, but also help open up a little more dollars for the treatment. And we have begun to see the numbers go up now in APRA over the last year of more people wanting to come in for treatment. So I'm really hopeful that this move will begin to enhance that even more.
SPA, you mean State Plan Amendment?
The State Plan Amendment.
Yeah, tell them. A lot of people know what the SPA is.
The State Plan Amendment is essentially, we've requested that CMS allow our providers to begin to start billing for substance abuse services. Now, it's not all services, and obviously we will continue to do more amendments to that State Plan Amendment, and my feeling is it's going to bring in significant dollars for treatment into the city, and we're looking forward to it over the next year.
Just out of curiosity, when you do the comparative data, you're comparing us to what? What kind of entities? States. You okay with that?
Yes, I am.
You are? Well, I wish you would stand up with us then and fight the battle to be really a state, okay? Don't you get tired? Don't you get tired of the comparisons always being the district is 47, 48, but yet, you know what? We're not 51 and really being a state. Wouldn't it be nice to be number 51? So fight the battle with us.
It would, and about 30 years ago, I came up with the slogan, DC, the last colony.
Yeah, well, it still is the last colony.
Still is.
And by the way, not a whole lot has changed in 30 years. So we'd love to have, as you work with us to help us create this new approach, fight the battle with us also for statehood. Thank you for that opportunity. Ben?
Well, I mean, as long as we're talking about the difference between cities and states, I mean, several of you said that this combining these two agencies puts DC on a more progressive direction in treating mental health. How, I mean, compared to other cities, how are we doing here?
Well, it's an interesting question, and again, I'll engage both of our leaders here. But a lot of times you find, when you look at mental health functions, they oftentimes are state-level administered functions. Substance abuse may range in terms of how it's administered, but virtually in the other 50 states, they are state-level functions that somehow then are certain functions are delegated down to cities. Now, Steve actually ran the Baltimore, and I'm going to ask him to talk a little bit about how that was organized.
Thank you, Mr. Mayor. Now you've given me an opportunity to bore the crowd. In Baltimore, we were set up as a quasi-public agency, but it was really state-driven, as the mayor said. Policy, funding, it was predominantly a Medicaid reimbursed system. And unfortunately, in mental health, if you look around the country, very few jurisdictions look the same in how they're organized and funded. So in Baltimore, the population who we know through our, boy, I'm going to get too inside baseball, through our managed care organizations, and the managed care organization in D.C. has a responsibility to provide mental health service to them in an outpatient. In Baltimore, they didn't. So the counts were different. But all I can tell you in the district with mental health, we have grown the number of people seeing. Almost, we were probably at 15,000, 16,000 3-4 years ago, and we're about 22,000 people now being seen. I have exact numbers in my packet, and I'd be glad to share with them. So once our providers, and I think one of the things we have done is really created improved stability in the public system, and our providers are serving more and more people, access has become easier. Still a challenge, but we've really focused on access. What Dr. Levin has said about the state plan amendment coming over to APRA, we have a tremendous amount of experience working with Department of Health Care financing and maximizing Medicaid. Actually, the number I gave Mike DeBonis did not include a lot of the Medicaid dollars that support the system, which is in the neighborhood of another $50 million. So that we've really maximized the services as other states have done, and now we need to fill the gap to what is not a Medicaid covered service. So it's very hard to make that distinction. I will tell you, I just had a phone call the other day. Baltimore is struggling with the same challenge, and they're working to integrate two large quasi agencies into one behavioral health entity. So this is very consistent with the national movement.
I think that would put the dollars somewhere in the neighborhood of $250 million, right? With the Medicaid dollars, with the other federal block grants, as well as the local dollars, with the two combined, we're talking about $250 million, which would be an enormous agency. You know, part of this discussion, I think, also illustrates the complexity of a jurisdiction like our city, and that is, you hear it, but this is a concrete example of being a state, county, and municipality all rolled into one. Medicaid, for example, would not be run by any municipality elsewhere. It is a state-run program. Mental health is a state-run program elsewhere. Certainly some of the substance abuse services are locally run, but even still, their relationships with the state to some extent. So we're having to do these things as one jurisdiction, which hopefully gives people an appreciation for the complexity of the challenge. All right, Mike.
Mr. Reyes, since we have Dr. Levin here, is it possible to just talk just briefly about the flu situation?
I have to tell you, that was perfect, Mike. I don't know if you saw he and I just talking, and we were talking about, at the end, he wants to be able to make an announcement about the flu. So thank you so much for doing that. All right.
Thank you, Mr. Mayor. One can never, as the state health officer, lose an opportunity like this with the press here and with all the people sitting in this audience to say that we do have a flu serious. It's not an epidemic, so let's get that word out. CDC has not agreed that it's an epidemic. An epidemic has some really sort of statistical significance more than actually what it happens in the, on the baseline when you go to the clinic. So I urge every one of you here, if you haven't had your flu shot, it's time to go and get it. Because for the simple reason of this, that if you do get the flu and you haven't had the shot, you will have, as we know, that essentially the flu virus today is a lot more severe than what we've had in the past, H3N2, which is why so many of us are going down for 2 weeks or 3 weeks. I can tell exactly who's had the flu shot when they tell me how ill they've been and how many days they've taken off work. Those that haven't had the flu shot tend to stay a lot longer in bed and off work than those who have the flu shot. It really decreases the amount of time that you're going to be off work. And so I urge you all, go now. There are, in the District of Columbia, your physicians, the health clinics, your pharmacies still have the flu vaccine. So I really urge you all to go and do that. We have seen significant increase in numbers from last year's flu season, but this year's flu shot truly does cover the three essential sort of flu viruses. I don't want to get too technical on you in terms of A and B and then sub-As, on it. So that's what I urge you all to do.
We've heard about some pharmacies being out of the vaccine. Is that something that the department gets involved in making sure that there's not shortages or that the sort of supply chain stays intact there?
Correct. And at this moment, all the flu manufacturers still say that they do have the vaccines. So all it will take is those pharmacies actually then contacting their head office and directly then buying the supplies to come in. Obviously, we do have a small stockpile, at DOH if we do need to give them some samples or some flu vaccine ahead. But I don't think that's going to be the issue here. At least none of the pharmaceutical companies have come to me yet to say that they need some intervention and some help.
A few years ago with H1N1, the city actually ran clinics and gave people flu shots. I mean, is there a possibility that would be an option this year, or is at this point the sort of private infrastructure taking care of it?
A few years ago, I was the Vice President of Science, Medicine and Public Health of the AMA, and in some of that was one of the big issues for us with H1N1 is how do you get the vaccines out to every doctor, to every health clinic? And I think we learned a lot of lessons from H1N1. And in some ways, the CDC has been really helpful with the states and with the District of Columbia to ensure that those lessons have been implemented in terms of making sure that we have a comprehensive coverage across the district. So I don't think the District of Columbia is going to need to directly, Department of Health, begin to run flu clinics. I think we have coverage enough in the city. Okay. Correct. As the mayor reminds me, we also have a healthcare delivery, in some ways a private sector, not-for-profit healthcare delivery system. The Unity Health Clinics are here. You're also seeing that immunizations from the school-based clinics are also working. So I think in some ways we're doing well. Our big problem is getting everyone to understand you cannot catch the flu from the flu vaccine. And in fact, if you do feel, I get a little irritable, I feel a little fluish when I do take it, that is basically your body telling you it is building up those antibodies in there to fight the flu when it does come along. And if you do catch the flu, those antibodies are there to really decrease the amount of time you're going to be off work and feeling better. Yes, obviously the elderly, anyone over 65, clearly needs to make sure that they get the flu vaccine. If they do have some concomitant chronic diseases such as diabetes, hypertension, chronic obstructive airways disease, if they don't do well, have asthma, they really should go and get the immunization. In terms of pregnant women, you should definitely make sure that they also get immunized. And essentially what we're looking at even in kids, that essentially after the first 2 weeks, literally, if you need to give a kid the vaccine, you can give it. It's in a different dosage that we do it. But clearly anyone who is immune compromised, HIV as well, should also look. And you have to also just remember the way it is spread is through coughing. I always like to say, don't forget to do the Dracula cough into your arm, and ensure that you wash your hands a lot. Every time you touch a doorknob, or a door handle, that is essentially where if someone has flu and coughed into their hands that they are touching. So you want to make sure you wash your hands frequently or have your sort of the alcohol sanitizer. So it's basic public health ways of ensuring that you take care of yourself.
Did I do that right? All right, we want to thank everybody for being. We want to thank, of course, our two directors, our deputy mayor, and the three folks to my left who obviously are leaders in one way or the other in the provider community and the bringing of folks together who are involved with behavioral health. And we will be looking to you all to work with us on over the next several months as we get ready to launch this. And then, of course, once we've launched, to be able to continue to refine the new department. Thank you all very much.